against him in the College of Nursing and is taught as a full-time faculty for the past 5 years. And if you guys went to the last ENA conference, he presented there. And this is going to be a great presentation. So during this time and for the past 10 years, he's worked in a busy ear, nose, and throat clinic. He is currently certified as an FNP and splits his time between teaching, clinical work in ENT, and volunteering with Utah County Search and Rescue. He has developed a well-rounded approach to both pre-hospital and hospital patients. He enjoys spending time with his family, especially the outdoors here in Utah, climbing, trail running, and reading. He has been actively working to climb every major peak in the Teton Range and checked off 2 more summits this past summer. So that's awesome. And with that, Scott, I will end this and stop sharing and turn the time over to you.
All right. Well, I'm getting my screen share up and going. Can you guys hear me okay?
Hear you great.
Let's make sure this behaves. All right.
And while you're sharing, I launched the pre-presentation poll and I haven't seen anybody answer that question. Do I need to relaunch that? Do people see that?
Jamie, I see 15 responses.
Oh goodness, maybe it's just me. There we go. So I'm going to share this just so you can see, Scott. We've got mostly nurses and EMTs and paramedics on today.
Okay.
Not all of them are super familiar with search and rescue. Some of them are. And then familiar with wilderness medicine. So you've got a great teaching group going.
Cool. Awesome. And I have a question because a lot of this is similar to what I shared at ENA. Did anyone get to go to ENA this year?
You can come off mute, raise your hand if you know how to do that in Zoom. Seeing a lot of no's in the chat.
All right. And then last question, since that makes me a little happier that this won't all be repeat or too much repeat. Can you guys see my slide? All is working well?
Yes.
I always want to make certain that you're not just talking on a blank screen. That kind of ruins some of your engagement right there. Well, so I labeled this one bad decisions fueled by testosterone because if you were to ask my wife, that's what she would say got me to sign up for search and rescue. She's like, that was a dumb decision. How much you get paid for this? Oh, I don't get paid. And you're paying money, you're buying new gear. And I thought this is exactly what I want. But that was the first bad decision that we're going to talk about today. And then we're going to get to talk about some more bad decisions that can be fueled by testosterone. And hopefully we'll learn something from that. We're going to go through a case study, which I think is really very appropriate being autumn time. We'll talk a little bit about hypothermia. And let's make sure this is. So our learning outcomes. So one, I want you guys to learn a little bit about search and rescue here in the state of Utah. And if you do want to get involved, how you can get involved. Two, we want you guys to think like a rescuer, and we'll go through a quick case study of search and rescue. And put on your hat of like, what would I be thinking? What would I be concerned about? And hopefully get a little participation. And then lastly, I want you to learn about how, I got to get my screen squared away. How you can learn about other certifications, things that you could do, whether EMT, nurse, whatever your background is in medicine, what you could do to maybe further your own training and be a more adept to help in a situation like this, or even if you did want to do search and rescue down the road, what things that you could potentially do. So those are my objectives that they asked me to include. Unfortunately, I have no commercial interests. I wish I did, because I'd be making money, is what I was going to say, but I'm not getting paid. So if you want to pay a lot of money, donate to your search and rescue. Actually, I have a lot of great friends up on Salt Lake Search and Rescue. I did a big training in Moab this last weekend with them and had a blast. And so I wouldn't even be sad if you donated to Salt Lake County, but you can always donate to Utah County too. We're just as poor down here. So a little bit about my background on search and rescue. Or even just background on search and rescue here in Utah. So it's, for most of Utah, it's a free resource. And I shouldn't say most Utah, it's free for anyone that would call for search and rescue and need that assistance. But there are a couple teams that actually get paid. Like Grand County over in Moab, they actually get a small stipend for being on the team. But when I say a free resource, that means, you know, when bad things happen, we prefer that potential victim, patient, whoever calls to get help rather than creates more problem for themselves and for others. And so it's ran locally through their local county sheriff, and they would dispatch at that point. It's a volunteer organization, and the teams vary in size and specialty to that surrounding community population. So like, for example, I'll speak to Utah County just because I know more about it. We're kind of a generalized team because we have Utah Lake, which is a large water source. We have flat water. We have the Provo River, so we get some swiftwater rescue in there. We have some decent mountains around here. That's what brings a lot of people to Utah. So we get some mountain rescue. We have a canine team for missing persons, a horse posse. So we're kind of a generalized team, but then within that generalized team, we have some specific roles. So like I really like the mountain rescue, have a little bit of a background in rock climbing and mountaineering. And so I tend to gravitate more to that. But, you know, everyone brings a different experience level. And that's one of the great things about search and rescue. So a little bit about me. I'm a newer member. I've only been a true member of search and rescue for the last 2 years. And I say that because I want you guys to know that like that first year for members, they call it your probational year. And because it does take a lot of time and effort sometimes to be on the team, you're balancing your work schedule and your recreation schedule, if that's a real thing. I like to pretend that it is, maybe. And if it doesn't work, then we don't want someone who's frustrated on the team. And so maybe you say, yeah, maybe it wasn't the best for me and I'll step away. And that's totally cool. There's significant trainings that you get involved in that first year with everything from, you know, practice rescues, different things like that. And then you actually get involved in the real rescues on your team, where you get called out, paged out. And so I just threw up a couple pictures. This was me. I got to fly in the helicopter to the top of Tim to go pick up a patient, and then just doing some training with our litter and on the mountainside there. But yeah, a lot of fun. Typical example of a SAR call. So how it usually will work, well, I guess one thing I would say is your typical time frame is, you think, when are most people recreating? And so here in Utah, that's going to be in our summertime. And that's why it worked so well for me where I teach, I get most of my summer off. And so it worked out great that I could say, hey, there's the increased volume of calls during this time frame, and so I can be more available. And those calls can be, you know, they send out a page and they say, hey, we need the team to respond to Timpanuki trailhead on Timpanogos. This is the equipment we need. This is a little bit about our patient. And it could be something as simple as an ankle sprain and you know, you're hiking a patient off the mountain, or even put them in a litter and help carry them off the mountain, to something as complex. I don't know if you guys remember the 2 young ladies that went missing on Utah Lake last March. And that was 10 days in cold weather and back and forth. And so it can be, you know, these really quick rescues to things that can be quite long and involved. And so we just radio into dispatch and say, hey, I'm responding. This is Scott. I'm coming from Lehigh. I'll be there. And that kind of gives the team leader an idea. Okay, who's coming? What kind of help do they bring? You know, what experiences do they have? You know, whether it be medical skills, rock climbing skills, whether leadership do they bring, so they can plan those resources and equipment that may need. And then sometimes there's multiple calls going on at the same time. That's pretty rare. I think the most we've had was like 5 calls in a 24-hour period, and it kind of stretched our team pretty thin. It was quite involved. So to begin, let's do a little case study. Does anyone recognize this area? And if you guys want to show your picture, I think I can throw up pictures. this teaching online, I love and hate it. I just love to hate it mostly. And so if you're on and you show your picture, if you recognize that and you want to chime in, great. If not, I'll just pretend like I'm talking to myself, which I do a lot of, and I can do that. So I'll answer this
a lot
first
of
one.
Bridal Veil Falls in the chat.
Oh, Jamie, bless your heart. All right, yes. So this is Bridal Veil Falls. We don't do a ton of rescues up here, but last fall, and that's why I say it almost works perfectly for this being your autumn series. But Paige went out late fall to respond to Bridal Veil Falls up Provo Canyon, and they asked for technical rescue equipment. So for a mountain rescue, it was probably around 7 o'clock at night. So you know that it's dark at 7 o'clock at night. Yeah, we call that the classic, your pumpkin hour, where it limits air support. So if you had, if you wanted a life light or have some sort of air support for extrication, that limits those resources. Makes finding your patient a lot more difficult working in that, increases risk to your team, moving in the dark on the cliff edge and different things like that. But what had happened was a 20-ish-year-old male went hiking with his girlfriend. They went up to the base of the falls. He kind of got cold. She got cold and said she was going to return to the car. He wanted to keep exploring, and he was reported missing around 8:30. I initially had said 7 o'clock. I just remember it was dark. So he went missing around 8:30, called it in, and they sent out that page around that time. So I responded. And this is just our team in the parking lot. This is actually a couple of our team members, and they're making assignments. So you'll have an incident commander that will say, okay, we want a hasty team, which is typically, 3 to 4 members that can move quickly and hopefully get to that patient. On this evening, I was actually on the hasty team. Me and 2 other individuals grabbed some ropes and hustled up this side of the falls. I was medical for the hasty team, and then you have your true team leader. Then we had another medical team that was going to be coming up with full medical equipment. We had our safety and our extrication team, our technical rescue lead, and so all these different roles that are happening in the background to hopefully, as you identify problems, you can quickly resolve them and have everything that you need and equipment wise. And so our response, I like to say it was like playing Sherlock Holmes. The first thing that they had given us is they said, hey, it's this young male. He's wearing basketball shoes and shorts. He had a 20-ounce bottle of Sprite, and his girlfriend's here at the car. So as we get up there, we're looking around, and most of the people are off the, it's not a common time to be up there anymore. Everyone with their families had left by this point. And we're kind of working our way up to the base of the falls to where he was last seen by his girlfriend. And I see a little lanyard, an LA Dodgers lanyard with keys on it. And I said, his name made me think of he would be a Dodgers fan. I don't know why. I like baseball, but I was like, man, this name sounds like an LA Dodgers fan. So I snapped a picture of it with my phone and I sent it down to the deputy that was with his girlfriend. I said, hey, are these his keys? And she's like, yeah, those are his keys. And so we found that on there. And the other thing that was weird is I found this half-drank bottle of Sprite sitting perfectly on a rock. And I thought, that's just weird. No one, people will set stuff down and people litter, but it just didn't seem right. And so it was kind of on the top of this steep embankment. And so what I did is I rigged an anchor and a rope and just kind of rappelled down that scree slope. And I found a little bit of blood right at the bottom of it, kind of down on the base of the rocks. And I thought, this looks pretty fresh. I bet we're heading in the right direction. And so, that's our blood trail. And so, that sounded really gross right there, but I don't know if anyone has hunted in the past. I grew up in Idaho, but that was our blood trail. And so to stay with the Sherlock Holmes theme, our game is afoot, meaning we got to follow this patient's trail. And at that point, what I did is I rappelled down, and it would be like a cliff band. and then kind of another scree slope, and then another cliff bend, and then another scree slope. And I just kept working my way down, and I'd find a little bit of blood and then nothing. And so I'd kind of go back and forth and like, well, the rocks maybe look like they moved through here. Then I'd find a little more blood, and I'm like, okay, he went through right here. So that would kind of change my line as I worked our way down. I found a pair of shorts, and I thought, well, these could have been up here for a long time, but you know, is this the right trail? And I followed it all the way back down to the base of the falls where it connects back to the paved trail, and never found our patient. And so at this point, people are like, well, maybe all that blood, maybe it was more than what truly was happening. Maybe he's fine. It looks like a lot of blood, and he caught a ride back into town. And I was like, guys, I found like chunks of scalp. And I thought, no, this isn't like if he got a ride back into town, someone would have said something. And unfortunately, the team leader that was down in the parking lot had called off the ambulance because they were needed somewhere else apparently, and said, hey, we don't need the ambulance. We think he's left. And I remember walking on the trail kind of back and forth. I'm like, something just didn't feel right. You know, you get that gut feeling. And so working my way back and forth, and I continued to search in that thick brush. And I remember yelling his name, and very last second, I kind of hear this kind of faint moaning in the trees. And I thought, and and you're right by the river, it's kind of loud. And I told my team, like, hey, everyone be quiet. I thought I heard something. And they're like, hey, I didn't hear anything. And I'm yelling his name again. I hear again this kind of faint moan. And I'm like, he's in this thick brush here. So I just kind of jump through this little creek, and I'm tearing through the thick brush, and I find our patient. And he's huddled at the bottom of this scrub oak, kind of at the base of the creek, completely covered in blood and dirt. Like it had, when he'd fallen, I told you I found a piece of scalp. It wasn't like he'd been scalped by like a Native American or anything like that. But he lost a pretty good chunk of flesh off the top of his head, and just blood. You know, scalp lacs will bleed like a stuck pig. He had just blood all over him. Somehow along the way, he'd lost his shorts and just completely covered in dirt and blood. Looked like a large rock. And that's probably why we didn't see him, you know. And I guess timeline wise, you know, I said the page went out at 8:30. We hustled up to the top. Let's say we got there. We all got to the parking lot at 9 o'clock because we're coming from different parts of the valley. Let's say best case scenario, we got to where he was last seen at 9:30. And then working our way down this cliff bend, you know, in talking about it takes 2 minutes, but this was getting late. This probably after midnight by the time we found him. At this point, he was alert. You could hear him moaning, not truly verbal, significant scalp laceration, multiple other lacerations. And so I guess my first question to you guys is, what medical concerns would you guys have at this point? Any of our participants want to throw up something on the chat or?
I'm saying, don't be afraid to come off mute as well.
Yeah, throw something. We got all the time in the world. As I said, I had to leave early for class, but so some of the big concerns, I guess, that come to my mind. So, why isn't my thing working?
We've got a couple of responses in the chat. We've got a debridement, acute injury of the limbs, hypothermia.
Yeah, so those are awesome. Thank you. My chat didn't show up. That's what I was playing with on my mouse. So
spine injury as well.
Yeah, and so my first concerns was I rappelled down some pretty good cliffs that it looked like he had fallen down based off of his blood trail. So I was like, man, significant risk for a C-spine injury from that height. I saw the chunk of scalp on the rocks. So I was like, he could have a concurrent head injury. Hypothermia, someone put up there. Thanks, Diane. Looks like a couple people put it up there. Yeah, mild to moderate hypothermia. I didn't go into all of his background. I found some drug paraphernalia that could have led to his altered mental status. You know, there all sorts of different things come to mind, but these are the big ones that came to my mind. C-spine, hypothermia. I do want to briefly talk about this because this was a concern of our medical lead that also came up with this as suspension syndrome. And I don't know if you guys have ever heard of suspension syndrome. Sometimes it's also called orthostatic intolerance or harness hang syndrome. And that's probably where you see it most commonly is, like someone becomes unconscious, whether they were rock climbing and got hit by a rock or took a significant fall, and then they get stuck hanging in their harness in that kind of upright position with significant limited mobility for a long period of time. And it can actually lead quite rapidly to death if it's not properly recognized and treated. Well, even though he wasn't in a harness, we assumed that he probably had been in this kind of fetal squatted position for a prolonged period of time in concordance with some mild to moderate hypothermia. And so that can all lead to severe impaired blood return to the heart. That lack of mobility, you lose that venous support that helps return blood to the heart. If they were in a harness, sometimes that will compress those veins and can lead to like toxins building up in your extremities, increased lactic acidosis or that lactic acid. And so, and I should have been scrolling ahead as I've been doing this. I got too excited talking, but as that blood settles and you lose that venous return, your body starts going through anaerobic metabolism, which increases that lactic acid production. There have been some studies that say some of those toxins can even cause, kidney issues from, and I don't know if you're getting full muscle breakdown from, like rhabdomyolysis and that myoglobin that's leading to nephrotoxicity. It was talked about in a couple of the studies I looked at in preparing for this, but there's a little bit of back and forth. But all those become concerns for this patient at this time. I think the bigger one was probably the moderate hypothermia. And initially I said mild to moderate because he was alert or somewhat verbal. And we'll talk about how you differentiate between your varying stages of hypothermia. But at this point, our patient was no longer shivering, which pushes him into the moderate staging for hypothermia. He was alert, but he was confused. So that puts you at what we call stage 2 hypothermia or moderate hypothermia. So typically, as we know, with hypothermia, our body to increase heat production, we're going to start shivering. Increases our metabolism. You get some profound vasoconstriction, which then shunts the blood from our extremities back to our core to keep our core nice and warm. Our heart rate starts to slow. We get some decreased cerebral perfusion. And these are all just some of those classic physiological effects that you'll see to help reduce some of the demands of our body and to reduce profound risk associated with hypothermia. As that continues to progress, you can see significant neurological changes. So even more than just being confused, you can have that as that brain starts to cool off, irritability, apathy, lethargy, somnolence, coma, and then death. Some of our cardiac changes, you start to see arrhythmias, atrial fibrillation is a common one that you can start seeing. And then it'll progress to bradycardia, and then you can have, depending on what happens, ventricular fibrillation, asystole, different things along those lines. And so one of the things that, since this is injury prevention, we should probably talk about what our biggest way to treat hypothermia, and that is prevention. And so how do we lose heat? And this is just a quick background on heat loss. So we can lose heat by a lot of different ways. As you can see here on the slide, conduction of, if we're on a cold surface, we're going to conduct that heat into that cold surface. And I like to think of hypothermia is we're essentially giving our heat away. We're not getting more cold. We're just really good at giving our heat away. And so we got to reduce how quickly our body gives away heat. So, through conduction, we needed some sort of insulating layer to keep us off that cold ground. Convection, just like your convection oven that blows that warm air around. Well, convection is we have cold wind blowing across those exposed surfaces. We're going to drop temperature. Evaporation and respiration, that's our primary form of evaporation. As we breathe out, we're going to lose a lot of heat. And then lastly, radiation, as it just kind of radiates off our body. And is I keep trying to bounce back and forth between my slides and looking at the comments. I'm going to quit looking at comments just to make certain. But anyway, I didn't click ahead. So these are just those 4 points we just talked about. So what can be done? So we can minimize the effects of heat loss by good choice of clothing and shelter, avoidance of exertion. You know, if you're going to be in the backcountry and putting a lot of effort, maybe taking off your heavier coat so you can, instead of getting that sweat that will then make your clothing wet and then can cause problems with its ability to wick heat further on, maybe we turn down our rate of exertion a little bit. That'll keep us dry so we don't lose heat as easily. Staying well hydrated can be very helpful. Maintaining adequate nutrition so you have those calories to help with that metabolic rate. Things that I would tell you to shy away from: tight clothing, especially clothing that doesn't wick. You know, so like our cotton fabrics. Smoking causes some vasoconstriction. You know, patients that have diabetes, peripheral vascular disease can also lead to decreased thermal regulation, hypovolemia, head injury, sepsis, so ETOH use. So even our patient here in our little case study, you know, head injury, possible ETOH use. He wasn't in tight clothing. He took his shorts off, so we know that wasn't a big deal. But kind of things to be thinking about. Smoking, I did find marijuana there, so maybe he was smoking weed or different things like along those lines. But I want to talk a little bit about some of those stages of hypothermia, those physiological changes. So mild hypothermia, this is where it's super important to recognize what's happening with your patient and make those changes so that it doesn't progress to moderate to severe hypothermia. So if you have someone who's starting to lose some of their fine motor coordination, they're shivering, and we've all shivered before, but to the point where like, hey, now they can't, you know, that with that loss of motor coordination, they can't operate normally. Their shiverings become so much. They start to slur their speech, you know, changes in their gait, their heart rate goes up. You can see some cold diuresis. Your patient can urinate more. And then if it continues to progress on, you know, that shivering is going to progressively inhibit itself until it stops. And then you start seeing some significant mental status changes, even more significant loss of coordination. And with those neuro changes, it can even progress to loss of consciousness, arrhythmias. And this is where it's not clear between mild or moderate to severe. And that's why with our patient here, he had lost his shivering. And so I easily could say, hey, this is moderate hypothermia. We need to change right now before things get worse. And so I included this. This comes from the Wilderness Medical Society, WMS. And I got permission to share this, but if we wanted to follow through this, I don't know if you guys can see my cursor on here, but you know, we have our patient, we suspect hypothermia. Did he have normal mental status? No. Was he shivering? No. Was he conscious? Yes. And so right there we can say moderate hypothermia, treat as above, active rewarming, circulatory access, volume replacement, no standing, walking, you know, give glucose, different things along those lines. And so let's take a second and kind of walk through this, and then also this little, they call it the cold card. This is from out of Canada, but for our patient, once again, you know, if we were to go through it, he follow the outer circle, he's still conscious. So then we come impaired movement. Yeah, he did have some impaired movement. Oh, the not shivering. So he's in moderate hypothermia at this point. He could progress to being not alert, but we caught him kind of between that third inner ring and that fourth. And it goes through what you'd want to do, handling gently, keeping horizontal. And that's what we're going to talk a little bit about here in a second. And so what is our field treatment for hypothermia? So first and foremost, if he had wet clothing, or if your patient has wet clothing, you want to remove that carefully. You don't want to jar your patient and get this significant cold rush of blood from one of the extremities that hits their heart and cause an arrhythmia. And so you very carefully removing their wet clothing, keeping the patient in a horizontal position. You know, if you raise their arm, that can, you know, or if they stand up, it's going to increase that venous return to the core and can cool them down significantly. If they're alert and can swallow, giving them high energy carbohydrates, anything that you can to fuel metabolism, help them get back to shivering. External heat sources, so applying it to their upper chest, the axillary groin region, obviously not directly to the skin, so you don't cause, inadvertently to burn them, because they're probably going to have decreased sensation there. What's not helpful, putting them in warm water. That can actually precipitate arrhythmias, and so you wouldn't want to do like a warm water immersion. And in the field, you don't typically have a large warm water source. It's not like you have a hot tub you can just drop in your patient. Rubbing the extremities, as we see on the movies, they'll take their hand and start rubbing their hands. You produce very little frictional heat. You can actually damage that underlying tissue, especially if they had something like frostbite or different things like that, where you actually had ice crystals in the tissue. That can be very problematic. This picture is actually, in interest of time, we won't go to it in detail, but I participated in, I got my diploma in mountain medicine, and part of it was doing a hypothermia lab. And so we all took turns getting hypothermia to see what it feels like, and it feels like crap. My whole body just hurt from shivering, and it was quite exciting there for a little bit. So I think the most important thing with field treatment is early intervention. Try and catch it before it becomes problematic. One of the best things you can do is what's called, some people call it the burrito wrap, but essentially what you're doing is you're wrapping your patient up, and you're trying to account for those different ways that we lose heat. And so if you look at this here, we have our plastic tarp on the very outer layer. That prevents any convection. So as a cold wind blows across that, we have that nice barrier that prevents loss from convection. Then we have a blue pad that prevents conduction loss. So we get them up off that cold ground. And then we put some insulating layers. So whether it be a sleeping bag, a blanket, and you do that above and below them to start to trap in some of that heat. And then the inner layer of plastic or foil, if they're not wet, this isn't as important, but if they're a wet patient and you're unable to get them out of their wet clothing, then you don't want your insulating layer to get wet. So I'll put them in like, our classic space blanket. And then you can see we put, a warm water bottle on the core, in the armpits, on the chest. And then you take and you wrap them all up, and you make you a nice little burrito, and try and do everything you can to let them start to warm themselves. If your shelter transport is less than 30 minutes away, you got to wrap them immediately if they're in wet clothing. If it's more than an hour, 30 minutes away, like an hour, then you could potentially get them out of that wet clothing, or use that vapor barrier internally. And I've used these on multiple hypothermic patients I pulled out of creeks that were 3-4 miles back in the backcountry, and it works wonderfully. And it's stuff that you typically have on hand. And so something that's very helpful to utilize for our patient. So first and foremost, we want to control bleeding. His scalp wound, it wasn't actively bleeding significantly at the time. It's still oozing a fair amount. So we controlled the bleeding. We stabilized the C-spine based off of his mechanism of injury. And then we also started some IV fluids. So warm IV fluids, not always easy to do in the field. Most of that was done in the back of the ambulance after we transported him there. And then they also had encouraged us to give him sodium bicarbonate, one, to treat the acidosis from the decreased tissue perfusion, since he had been in, in that potential suspension syndrome, trying to dilute those toxins from returning back to, generalized circulation and support his kidneys. But what I truly think was the hypothermia care. I think if he had spent the night out there, he very well probably would not have survived the night based off of what had happened. Like I said, at one point, EMS had been told to stand down and had left. And so when we found the patient, we quickly activated EMS again to get their ambulance back up there. And we're able to extricate him and get him off the mountain, and, had them fire up their heater in the ambulance and do everything we could. And what's wonderful is our patient did great. He, was admitted to the hospital. I don't have all the background information because it was a hospital I don't typically not rounding at commonly. Anyway, so he gets down to the hospital, full return of function, no significant C-spine injury, mostly just rewarming and getting him back to normal. A lot of stitches up and down the back of his head and forehead and down his arms, but ended up doing great. So I guess the last little bit is, and I wanted to include this just for how you guys can get involved. So like we started out with, search and rescue, a lot of this is volunteer. And so maybe you want to apply to be a member of your local team. Maybe you want to find a way you can donate. You'll be welcomed with open arms. They're always looking for people that want to give back. Develop those skills that make you an enticing fit. So if you truly want to get involved in search and rescue at a higher level, and what's wonderful is we're talking to medical professionals here. You bring something that the normal community doesn't have, and that's something that we can continue to build upon. But there are other things that you can do. Wilderness Medical Society has some great resources, classes you can take. Diploma in Mountain Medicine. I completed my diploma in mountain medicine through University of New Mexico School of Medicine, and did a year-long course down there and had a blast and learned a ton. There's the Wilderness Registered Nurse, which is a newer program that teaches a lot of the search and rescue type skills, but to people that are already, have their nursing degree and can bring all the skills that they've learned at the bedside in nursing school, in the hospital, wherever the case may be, and then transform it into the wilderness or that austere environment and help them think in that way. And then lastly, this is my team, and knowing that if there are questions, I talked quick today, and so I'll have a little bit of time for questions right now. But if you have other questions or want more information on resources, I put my email up there. Shoot me an email. I'm happy to answer questions via email. But that being said, any questions right now? And let me just escape this and go back to my stop share. Oh, there we are. So what questions do we have right now? Or do we not? I was so good at no one has questions.
So Scott, I was actually thinking, so one thing I didn't know is just thinking about the fact of not jarring your patient to cause that cardiac arrhythmia. And of course, as you were talking about that, I start my Google search. And it doesn't look like there's a lot of information, but can you talk more on how that impact of moderate to severe hypothermia, how that impacts your cardiac activity?
Yeah, so there's a couple cool things that happen physiologically that your body will do initially. So obviously it wants to keep your core warm, your brain, your heart. And so you have your arterioles that have the little sphincter muscle at the opening of each arteriole that will constrict and cause this profound vasoconstriction. So it keeps most of the warm blood at our core. Well, over time, that muscle will start to fatigue and they'll fall open. And this is actually kind of some cool physiology that will lead into that, but I was kidding around about how he lost his shorts. Well, I don't know if you guys have ever seen, in the movies and different things, what they call paroxysmal undressing. So patients that they've found, up at high altitudes, like on Everest, and they'll have like their coat unzipped and their gloves off. And you think, man, this is super cold. Why are they taking their gloves off and their hat off? Well, what happens is as that muscle, it's constricted for so long, finally it fatigues. Well, all that warm blood at the core then hits the periphery and it feels really warm to that tissue. And so in that last little bit of cognitive process of them, like man, my hands and arms are so warm, I got to take my coat off, I got to take my pants off. Sometimes that patient will, we call it that paroxysmal undressing, they'll undress, which actually leads to further heat loss. But what happens at that same point is then all that cold blood in the extremity comes back to the core. And our cardiac tissue is very sensitive to temperature changes. A lot of our medications don't work as well when our body's cold. So, you know, epinephrine, which is one of our ACLS drugs that we would use to hopefully help in an arrhythmic state, it doesn't work as well when we're cold. And so as that heart tissue becomes irritable from the cold, it precipitates arrhythmia. Most commonly, you'll see early on is atrial fibrillation. And then as that continues to progress, you'll start seeing more bradycardia. And then if it continues to progress past that, you'll see whether it be VTAC, VFib, and then onto asystole. I don't know if that answered your question well enough, but
actually it helps clarify that you're not dead until you're warm and dead, right?
yes.
Because your heart's not going to function properly unless you're warm or it has those arrhythmias.
And there have been studies. There was a study out of Europe. I want to say it was in either Switzerland or Austria, somewhere in the Alps, of a young girl who fell through the ice, was submerged for almost over an hour, and had full neurological function when they resuscitated her, which is just beyond crazy to think about, but did really, really well. And so, yeah, you're not dead till you're warm and dead. And that's very, very true.
And we had, so Kathy mentioned in the chat, so she had mentioned earlier that she coordinates with the search and rescue team in Wyoming.
Oh, cool.
And then she does teach not to jiggle the patient in hunter safety and all her first aid and EMS classes. And then also not to rub them. And I can actually say, like, I've been through a lot of these classes and we put on a lot of injury prevention, but you're the first person to mention not jarring your patient during when they're moving, during hypothermia. So that's awesome information. And then we had another question about, just is everyone on your team a volunteer, or do you have anybody that is not?
So yeah, so we're all volunteers here. In working, so I'm not horribly involved in the state level. So like Grand County, which is Moab, they're a paid for search and rescue. I think it's not a lot. I think they get paid like $15 an hour while they're on rescue. So it's not like it's their full-time job. Or if it is, they're living the dirtbag life. But here, Utah County, Salt Lake County, 100% volunteer. There are a couple positions through the sheriff's office. So where if you were law enforcement, then and on search and rescue, that's no longer volunteer, like our pilot, different things along those lines. But for the most part, yeah, we're all volunteers. And so, yeah, that's why you have to say, was that a bad decision? Probably so, if you're looking at it from a monetary standpoint. My wife's like, man, you should just go pick up an extra shift and then you could buy all the gear that you want. But once again, a poor decision. Let's see, I can now see questions.
Yeah, you've got a couple in
Can you
there.
explain how some people are able to have full recovery when someone goes into a hypothermic coma, even for days? I can try and explain what I understand physiologically. So as we decrease the metabolic demand of our brain, because that's primarily where, you know, if it's not being and receiving oxygenated blood, that tissue is very sensitive and will start to necrose. And that's where you run into problems. And so if you can reduce that metabolic demand sufficiently enough that we protect their CNS, then yeah, then we can warm them back up and have complete resolution of their symptoms. And that's why even, you know, patients following a significant MI, will put them in, you know, hypothermia to reduce that metabolic demand. And, you know, we'll have them in the ICU and then slowly rewarm them back up and able to get that well oxygenated blood perfusing back to their brain, and so they can have that full neurological recovery. And I don't know if that answers Cortland's question. If there was more to that, you can chime in or come off mute. And we'll say that was good. Okay, Kathy, what if the temperature to rewarm them before you stop resuscitation? So they're back to being back to, you know, our normal body temperature. So that's that classic, you're not dead until you're warm and re-dead. Unfortunately, I've also been involved where we've tried to resuscitate patients in the backcountry, which, you know, you want to have the best hope for everything turning out well. And, you know, when we get them to EMS and they get them down to the hospital and finally rewarm them and not have great outcomes. And so, yeah, I guess I don't know what the hard fast rule is, but you know, warm and dead. So back to, you know, 37 degrees Celsius would be, I guess, where I would say, let's abort the mission at that point. But I think there's a lot of other extenuating circumstances that you'd want to look at before you know, you could look at potassium levels and different things like that. But, and that's the kicker when you're in this wilderness or austere environment, you don't have all those resources. So you just have to do your best. And hopefully you're erring on the side of being overly cautious, providing more care, but knowing that you don't have all of the resources that you typically would want and to make it easy. And so it becomes very challenging.
And I'll say, just because I looked up on American Heart Association, so you're rewarming anybody with a core temperature of less than 34 Celsius. So my guess is you have to at least reach 34 degrees Celsius to say that they're warm enough to stop that resuscitation. So Kathy, that's according to the American Heart Association.
That's a lot better answer. Thanks, Jamie.
I try and be helpful as we're talking about.
Yeah, I can shut down but I appreciate the backup. That's great.
Mm-hmm.
Any other questions? All right. Well, you guys have a wonderful afternoon. I'm gonna have to run, so I appreciate you guys and have a wonderful day. Hopefully, I don't ever see you guys on the mountain, or at least when we see you, we're both having fun.
Mm-hmm. That's what we always say. We love to see people out and about, but we don't want to see you in the hospital.
Amen. All right.
Thank you so much, Scott. I really appreciate your time.
My pleasure. Thanks, everyone.